So how important is exercise for prostate cancer? Not only prostate cancer, advanced prostate cancer. I'm talking about men with advanced disease on androgen deprivation therapy, men with bone metastasis, very advanced disease. How important is exercise? Today's guest is Dr. Robert Newton from Australia. So we spoke from Brisbane. And Rob is a professor of exercise medicine and deputy director of ECU Exercise Medicine Research Institute that he established in 2004. In 2020, he was appointed Vice Chancellor, Professional Research Fellow in Exercise Medicine Research Institute. And in 2018, Professor Newton received his Career Achievement Award from the Cancer Council WA in 2019 and was named Western Australian Premier Scientist of the Year for 2021. Now, you would think that with all these scientific accolades, and Dr. Newton has a lot of abbreviations after his name in terms of all the certifications and things that he's accomplished. But this conversation is practical. What should you consider doing as it relates to exercise in men with advanced prostate cancer? What are the type of exercises, with what intensity, how often? So we take the research that I'm so thrilled to have this conversation with Rob Newton, because almost all of the implementation that I do clinically with patients with regards to exercise comes from his research and his team. So this is a huge honor for me to speak with Dr. Newton. And we get into the mechanisms, how it works. There's anti-cancer properties in proper exercise with the right prescription. We go through it all, and you're going to have a blast. And hopefully you are inspired to get going and do the type of exercises that are important for you to keep well and stay cancer-free or manage it well. So enjoy this amazing conversation with Dr. Rob Newton on exercise oncology. Let's go. Before I proceed, I just want to clarify that this podcast and all Dr. Gio content is separate from my faculty position at NYU Langone Health. The views and opinions on this podcast are my own. Our guests and sponsors are curated by me and not affiliated with NYU Langone Health. Sponsors are a way for us to provide high quality information at no cost to you so that you can take better charge of your prostate health, testosterone, and erectile function, and also how to live better with age. Welcome to the Dr. Gio Prostate Podcast. I'm your host, Dr. Gio, where it is my intention to help you with all your prostate problems, bring clarity as to what you should do, natural, conventional, integrative, especially prostate cancer, and how do you do better despite such a diagnosis like prostate cancer. Today's guest, you know about Dr. Robert Newton. I'm excited. I'm stoked. I'm stoked because this is the research that I utilize to implement with patients. A lot of what I tell you on this podcast is from the research that people like Dr. Newton write about. And it's excellent research that most of you may know about already because we talk about it quite a bit. So no further introduction necessary. Dr. Rob Newton, thank you so much for being on. Direct from Australia, from Brisbane, huh?
Absolutely, live. Thanks, Dr. Gio, for inviting me for the opportunity to talk with you and to talk about our research and the clinical work that we've been doing over the last 20 or so years.
Thank you, Rob. Listen, I can't tell you, before we started recording, I'm like, man, this is like Michael Jordan. I'm talking to Michael Jordan. This is when you talk about exercise oncology as it relates to my love, the disease that I spend so much time, which is prostate cancer. You and your colleagues and Val, you guys have written so many great papers, practical papers that I've implemented with all my patients. So I can't tell you how happy I am that you guys do the work you do. When I was at Columbia University back in the early 2000s, I did some research. I was like, I don't like the research part. I want you guys to do the research, people that probably enjoy it, and I want to implement it. I want to translate it and implement it with patients. So that's what I've done lately, and it's been great. And it's brilliant. So I want to thank you for all the work you've done off the top.
Thanks so much. And I really appreciate these opportunities to actually promote exercise medicine in cancer management, and in particular prostate cancer. I've got a very personal interest in prostate cancer and improving outcomes for people with prostate cancer.
Yep. First question, Rob. Why? What? You could have gone into, I don't know, working with athletes. You could have gone into so many different areas, and you chose, probably because you look really good, but maybe we're contemporary. So I'm 52. When I started doing prostate cancer work was in the late 90s, early 2000s. And I think I've read research, some of your research before the 90s. So I remember back then when I spoke about integrative medicine and the importance of nutrition and oncology, and they were looking at me like I have three heads. So it was definitely the road less traveled for me.
Yeah.
It had to be the case for you. So why did you choose, to focus on exercise oncology?
I did start out in high performance sport, and I was looking at research on how to look at the basic physiology of how do you increase the size of muscle, the quality of muscle tissue, how do you increase performance. And one of the first studies that I did in the field was with old men. And this was looking at you doing explosive power type training, which was unheard of. We were barely giving strength training for older people. This was back in 1994 at Penn State University, and I ran a study trial there looking at young and old men and looking at them doing jump squats. They're actually doing explosive power training, or ballistic training as it's more correctly termed. And I just became fascinated with how they responded. But no, the first 20 years of my career was actually in high performance. So I was working with tactical athletes, so war fighters, working with elite athletes, NBA, NFL, and of course other sports like rugby in Australia. And I was very interested in that, and it was fascinating to work with that. But then probably in 1994, when I started working with older men, that I became more interested in as your age as well. And I'll be 63 next month.
Wow.
And
Amazing.
I think as you age, I wouldn't mind doing something a little bit more impactful, I guess, to general society. And so I got interested in doing this work with improving function and structure in older people. But it wasn't until about, when was it? 1997, 96, 97, around that time. My father was diagnosed with prostate cancer, and he had a prostatectomy. He then went for 6 weeks of radiation therapy, and they sent him home, or he returned home. He was frail, overwhelming fatigue, and he just didn't want to do anything. He'd sit in the sun at the front of the house, and I'd see him there, and he was miserable. He had urinary incontinence. He was in his mid-70s at this stage. And I said, "Come on, Dad, let's go for a walk," because he used to love walking. And I said, "Let's go for a walk." He said, "No, I'm just so tired, this fatigue." And as an exercise physiologist, every fiber of my being was screaming, "Look, this is not right." Just sitting there and doing nothing and watching him waste away, I realized that this strategy is not right. And so we went to see his urologist, and they said, "No, you've had cancer and we may come back. You've had a lot of treatment. You need to rest. You need to recover and get over it." And but I looked at him and said, "No, he needs to lift weights. He needs to his muscles were just disappearing. He was just wasting away." Well, 2 years later, he had a stroke and died. And I've got to be honest, you can't predict these things, but those last 2 years of his life were terrible quality of life. And you have to think whether, geez, if they just would have left him alone, okay, he may have had 1 year and then the cancer got him, but at least he would have had a decent year. Or he may have lived longer. And so that's from that point, around 1997, that I decided that I wanted to pursue exercise as a medicine for people with cancer, in particular prostate cancer. And then I was working in Indiana at the time at Ball State University, and I got an email, and I was invited to apply for a position back in Australia. And it was a full professorial chair, which there are very few of those in exercise science in Australia. And I got the position, but I pitched that on exercise medicine for cancer patients. I said, "Look, I want to do research and teach and do clinical work in exercise as a medicine for people with cancer." And it similar to your experience, people went, "You want to what?"
Right.
Should you just leave them alone? Really? And I said, no, I think it's got benefit. I think it's got merit. But at the time, that was the clinical recommendation: to rest, to avoid physical activity, and certainly not lift weights. Do not do any strenuous exercise. Do not do strength training. Again, I'd spent 20 plus years studying muscle physiology, neurophysiology. This is just it's not right. The human is not meant to sit, to lie, and not to move. It's just not right. Its whole physiology screams against that sedentary rest strategy. I was fortunate that when I started at my current university, Edith Cowan University in Perth, Western Australia, that the associate dean for research took me under her wing. Now, she was a nurse with huge experience, and she was actually the chair in cancer and palliative care. So we hit it off right away. And she said, Rob, I'd like us to do research in patients who are palliative with cancer. And even I went, ooh, okay. I thought, geez, can they exercise? Because these patients are obviously at end stage of life, they're quite unwell.
We're talking about stage 4, very advanced kind of stage.
Yeah, very advanced. And it was inpatient, so it was in hospital that she was proposing this. And so we did some pilot work where we had all cancers, these patients, and we had them actually lying in their hospital bed, and we had them doing exercises, predominantly strength training, so with light hand weights and stretch bands and things. But it was that point, first off, a very experienced nurse with decades of experience working with end-stage cancer patients. And she said, no, that'll be fine. It'll be fine. At the moment, just sitting there. How can it hurt? Let's just give it a shot. And so we started them doing this resistance training. My gosh, they just perked up. There was less pain, less anxiety. Their actual appetite picked up. So many changes occurred in these people. Now, of course, we couldn't test to see if it extended their life, but certainly the quality of life for these patients were greatly enhanced. And so I was encouraged by that, but my main focus at this point was to try and address the side effects of treatment for prostate cancer. And our early studies were in men on androgen deprivation therapy, and of course that's the most ubiquitous treatment for prostate cancer. And as you well know, look, it's highly effective for slowing the disease in hormone-sensitive patients, but the side effects are catastrophic. We published an early paper. One of our first papers was a cross-sectional study where we looked at the changes in these men over the first 36 weeks, I think, from memory. And my gosh, the loss of muscle mass was just astounding. I couldn't believe how quickly they lost muscle mass and bone mass. Their metabolic syndrome took off, cardiovascular disease risk, it was just through the roof. And whilst the ADT, highly effective at slowing the progression of the disease in most of these patients, the side effects were killing the patient. They were becoming frail, having heart attacks.
It's not the cancer in those situations.
Exactly. And this was a concern for our clinicians that we were working with, because they're saying we're providing these drugs, it's working well with the cancer, we're seeing PSAs falling and we're getting good control, but the quality of life for these patients is very low and the risk of all other chronic diseases is skyrocketing. Now, the problem was then that patients were starting to go, oh, no, I'm not taking that, and rightly because it was causing such, in particular, the cardiovascular issues that were occurring. Now, I looked at that and I thought, gee, muscle loss, fat gain, increased cardiovascular risk. These are prime side effects which should be ameliorated through appropriate exercise medicine. And again, at this time, the recommendation was to rest. And so, well, let's try some training intervention. So we initially implemented multimodal, so because we didn't know what would work. No one had done this. There's a few small studies previously, but we didn't know whether men that were castrate would actually respond to resistance training. Do they still retain the capacity to actually grow muscle when they don't have the anabolic environment provided by testosterone? So we launched a couple of trials to see that, and the outcomes were quite astounding. And one paper we published very early on, we used DEXA, which is gold standard for body composition assessment. And we found, on average, an 800 gram, I don't know what that is in pounds, maybe a pound and a half, of increase in lean muscle mass in these. These are old men that are castrated.
Let's pause there because I see that often in my practice, actually. For the audience, what Rob is saying is that typically men who undergo androgen deprivation therapy, there's a lot of side effects to it. And I certainly believe that a lot of the side effects come from loss of muscle mass. Once that happens, there's a lot of metabolic dysfunction. There's bone density issues. So the goal is to keep muscle at all costs. That's what I tell my patients. There's a certain amount of protein you eat. And Rob, we're going to talk exercise here. But just to let you know, in my practice, when you have people and influencers say meats are bad for cancer, that's not completely true when you look at the literature closely. But aside from that, the risk reward, you need good quality protein. And if you're vegan, no problem. Let's figure that out. Let's figure out how you can get the best quality protein possible. We need to keep muscle at all costs. So weight resistant training is important. So typically you lose a massive amount of muscle when you are undergoing androgen deprivation therapy. And what I've seen because of the research of Dr. Newton, and I've applied it, is that patients not only do not lose muscle, they actually gain a little muscle despite the fact that they have zero testosterone in their bodies when they're undergoing androgen deprivation therapy. That has been outstanding. And I've even tested them 2 pounds of muscle because they're taking a certain amount of protein and so forth and things like that. So remarkable, remarkable. And I don't see in my practice, in my men who are undergoing androgen deprivation therapy, I don't see a lot of metabolic syndrome. And we measure everything: cardiovascular risk, waist to hip ratios, grip strength. They do not tend to lose a whole lot of muscle. And the main side effects they have are sexual, but not beyond that. They're functional, they're working, they're doing great. Rob, before we continue, we're going to work a little bit backwards, because there's a study that just came out not that long ago in 2025 showing a systemic review that you published on all cancers and exercise. And what it showed was that those with higher muscle strength had a 31% lower chance of all-cause mortality. And even those with, let's say, lung cancer, digestive cancers, and so forth, roughly, they had somewhere between a 20% to a 40% of less mortality with their cancer than those that were not exercising. This is a systemic review that just came out. And those advanced cancer patients saw up to close to 50% lower mortality risk. This paper just came out in 2025. Rob, to me, that is, wait a minute. If you and I create a medicine that lowers the risk of mortality by any of these measures, that's $1 trillion drug. And we're talking here not prostate cancer only, we're talking lung cancer, which is a little bit more tough to handle, digestive cancers. The other element was cardiorespiratory fitness. This is like your aerobic fitness, or VO2 max, if you get that measured. Your ability to use your lungs properly, to use oxygen and so forth. You could get that measured in any fitness facility. Get your VO2 max, very important. That's the same thing as cardiorespiratory fitness. That also increased or lowered the risk of mortality in cancer patients. Can you expand what's happening here? This is medicine. This is not just, hey, it's cute, go do some exercise, you're going to look better, you're going to feel. This is medicine against cancer. So what's happening? What's the mechanism here?
We published in 2016 a paper where we proposed 10 mechanisms by which exercise actually alters the tumor microenvironment. It actually changes the systemic environment within the body. And of course, all cells in the body are bathed, including all cancer cells, tumor in tissue, but also circulating tumor cells. And through these mechanisms, they actually provide a highly suppressive effect. We've been particularly focused on 2 key pathways, and that is the cytokines, the molecules, peptides that are released from skeletal muscle. Now, these, as we call them, myokines, because they're released from muscle, and these are signaling molecules. They signal to all tissues in the body, and they actually do direct signaling to cancer cells. And prostate cancer cells is what we've mainly been looked at. Although I just read a paper this morning from one of my PhD students, so we're just preparing that, and that's in breast cancer. And we've seen similar suppressive effects. Now, these myokines include interleukin 6, interleukin 15, decarin, OSM, SPARC. These myokines, interestingly, if you isolate them and you actually expose living prostate cancer cells to these myokines, massive suppression of growth. So these myokines are signaling directly to the cancer cells, and they are driving cell death, autophagy, but they're also driving reduction in DNA replication and division. And so they're directly slowing the growth of these cells. The other mechanism we're looking at is the interaction of our muscular system with our immune system. Now, about 15 years ago, some brilliant work out of Denmark And what they showed was that our skeletal system is not just responsible for movement and for keeping us warm, it's also the largest endocrine organ in our body. This is a massive amount of tissue, and it pours out hormones and other signaling molecules like cytokines. Now, that role is crucial, absolutely crucial, and that's why we're seeing, for example, you mentioned people who are stronger, they seem to live longer with their cancer. People who have higher muscle mass also have much better survival, not just overall survival, but also cancer-specific survival. So having a high level of muscle mass, or at least not having a low level of muscle mass, appears to be highly protective. And it's related to these mechanisms by which our muscle system is signaling to all our other systems to say, hey, we're creating an anti-cancer environment here. We're going to get rid of this thing. And I mentioned about the interaction with the immune system. What we see is that when our muscles are producing these myokines, in particularly IL-6 and IL-15, and when we exercise, we produce adrenaline, and that stimulates the release of natural killer cells, and they pour into our circulation. They're activated by the adrenaline, but also we then have the cytokines released from muscle, which are actually increasing the surveillance capability. They're switching these natural killer cells and other immune cells, T cells. They're actually enhancing their capacity to recognize cancer cells and making them more aggressive, if you like, and better as cancer killers. And so that helps to explain why. The other mechanism is that when we exercise, our blood flow increases, our cardiac output goes up, and that increases the flow of blood through solid tumors. And so we're actually delivering more of these anti-cancer myokines and more of these anti-cancer immune cells into the, if you like, the deeper parts of the tumor. And so that explains why exercise suppresses the progression of these cancer cells. Now, what we also do is we exercise people. This has been well demonstrated in healthy people, but our work over the last 5 to 8 years has been in patients, because the question is, if I have cancer, I've got prostate cancer, I've had ADT for 10 years, I've had chemotherapy, I'm now having radiation therapy.
Is it too late? I never worked out in
my life. Is it too late? Can I still produce this environment?
If I start now, am I starting too late? Yeah.
And what we found in our study, so myself and Professor Fred Sard, a urologist researcher out of Canada, we co-led a study funded by the Movember Foundation. And it's the interval MRPC study, metastatic castrate-resistant prostate cancer study. We call it GAP4. Now, in that study, we looked at men with metastatic castrate-resistant prostate cancer. So incurable, essentially, at the moment, disease. And what we saw is these men can exercise, and we saw huge increases in these anti-cancer myokines when they exercise. And we also, when we took their blood and exposed living prostate cancer cells to that blood, we saw around a 20% suppression of rate of growth over 72 hours. So yes, even men with advanced cancer that have received extensive treatments still retain the ability to activate their muscle, for their muscle to change and to improve and to create a more cancer suppressive environment.
Unbelievable. Now, in today's conversation, this is not one of those podcasts where we are on for 3 hours. I wish, but I don't think that I'd be able to do that, or my audience would be able to listen for that long. So we're going to focus primarily on advanced prostate cancer for today's conversation. But I think it's safe to say that for prevention, man, exercise is medicine. For low-risk disease, there's a lot of research that I've talked about and written about with regards to men on active surveillance and exercise. No-brainer. Yeah. In terms of reducing risk of recurrence in men who get treated and they seem to be cancer-free, there again, more you exercise, the lower risk you have of recurrence, and then dying if you recur, if you exercise in a certain way, a certain intensity. We'll get into that. Advanced prostate cancer. So we already talked about men on androgen deprivation therapy. A lot of benefits that are related to the side effects from the ADT, and I think also as it relates to the cancer itself. There are some men with advanced prostate cancer that have bone metastasis. Yes. There again, I read the research from Rob Newton et al., and it suggests, men with bone metastasis can exercise, can do weight-resistant training safely, risk of fracture, even play what you would call football, I would call soccer. So you've studied men who play football and with bone metastasis, no risk of fracture, lifting weights, no risk of fracture. And so I want you to expand on that, because that is exactly the population where the oncologist is saying, hey, no weight resistance. Be very careful. Don't do too much. And the opposite seems to be true. Can you expand on that?
Thank you for watching the Dr. Geo Prostate Podcast. Take a proactive step and improve your health and vitality with the Prolon Fasting Mimicking Diet FMD, a 5-day plant-based program developed by Dr. Walter Longo, designed to mimic the effects of fasting without the challenges. Prolon helps activate autophagy, reduce inflammation, support weight management, and promote overall longevity, all while nourishing your body. As a special thank you, you can access the Prolon kit for just $148. Use the link below to get started. Empower your journey to better health today.
Certainly, probably the middle of last decade, the clinicians we were working with were concerned about the outcomes for these patients, these men. Advanced cancer, stage 4, many with bone metastases, many with extensive bone metastases, so lesions throughout their skeleton. And these men are on the super anti-androgens. So they're on drugs to suppress the production of testosterone from various tissues, but they're also on drugs which block the receptors on the various tissues as well. So the super anti-androgens have a whole new range of toxicities, if you like, as well, on top of the ADT. These men are really, whilst the disease is being controlled somewhat or slowed, the other issues that they're facing are quite considerable. Bone loss, muscle loss in particular.
That are much stronger include things like enzalutamide and abiraterone.
Yeah, abiraterone,
These very strong drugs, yeah.
Very. And look, to be fair, they're very effective at slowing these hormone-sensitive prostate cancer cells.
Correct.
At this stage. And it's well demonstrated they do extend survival. But they have side effects, of course. And so the clinician said, these men just aren't doing well, because we're telling them don't do anything, don't rest, the concern about fractures, etc. Is there some way we can exercise them so they can have some quality of life and maintain function? And so what we did, we came up with a training program, which I borrowed, I guess, from my 20 plus years of working in elite sport, is if someone at the New York Yankees,
the New York Yankees reference, I really appreciate that.
No problem at all. No problem at all. If they do a knee and the game on the Saturday, okay, the coach doesn't say, oh, look, go home and sit and watch Netflix for 6 weeks. That doesn't happen. The next day, the athlete's back in the gym. They're back in the weight room and they're lifting weights, and we just exercise all the bits that aren't broken. I was well experienced with this and working with elite athletes, and we just applied the same thing to the clinical realm. And we said, okay, so if the patient has through the PET scan, has a metastatic lesion, for example, in the thigh bone of their right leg, we just exercise
their pelvis. Their pelvis is very common.
Pelvis is common. Let's choose pelvis then. Then we just do a lot of upper body exercise. We do knee extension, knee curl, or knee flexion, but we just avoid placing a large amount of load through the pelvic area. And so this was a protocol that we came up with. We called it 3MEP for a multimodal exercise program, modular multimodal exercise program, 3MEP. And we implemented this in both the aerobic and the resistance training prescriptions that we did. And we did a series of studies on this, which we published. The main paper was published in 2019. And what we reported is that no adverse skeletal events, no increase in analgesic use, and considerable improvements in strength and quality of life. If it's done correctly, if it's implemented correctly, under close supervision, yes, it is safe, in resistance training included. These men were lifting heavy weights. These men are lifting weights that they can only lift between, say, 8 and 15 times. It's not fluffy balls and and balloons that they're lifting. No, they're lifting heavy weight. And that's a key. You have to give the right medicine at the right dosage. It's no good taking aspirin for your headache if you're taking a tenth of what the actual clinical dose required. The same with resistance training. You have to take the dose required to produce the adaptations in your muscular system, cardiorespiratory system, to produce the medicines that we're trying to stimulate to create an anti-cancer environment. So these men were lifting heavy relative to their strength levels. Since then, there's been a lot of research coming out around bone mets, so cancer lesions within the skeleton, and showing that if you produce controlled loading through that lesion, it seems to really shut down the growth of the cancer cells in the bone. So it appears that as when we do any form of movement, exercise, particularly weight training, the forces, the stresses that go through the bone cause the bone cells to produce chemical and electrical signals, which helps the bone remodel. It appears that those same signals are actually shutting down the cancer cells in the bone as well and suppressing those prostate cancer cells which have metastasized into the bone. So from there, what we did was we implemented a study where these were men with prostate cancer, women with breast cancer, where they had cancer lesions within their vertebral column. And we started to implement isometric spinal contractions. So very controlled exercise here, where they're just placing some loading on the sites of those lesions. And again, we saw no exacerbation of bone pain, no exacerbation of bone medication, and certainly no fractures. So on current evidence, appears that where possible to try and put controlled loading through the sites of these metastatic lesions, to use bone pain as an indicator of whether the loading is excessive. Of course, it's a gradual introduction of that loading, progression along. If you start to see symptoms of bone pain, for example, then you regress back again. And, it's very important. We have to keep these patients moving. We have to find a way for them to do high quality exercise without exacerbating their risk. I'm not so sure about football, mainly because you've got the problem of not the football itself, but you've got other players and the risk that they may fall. It's not the running around or the football that's the risk. It's the fact that they might have an accident and cause a fracture. But certainly in our clinical practice, we use heavy resistance training extensively with patients with metastatic lesions in their skeleton, and also aerobic training. Not so much jogging, they find that too difficult on the treadmill, but certainly we're really getting their heart rate up on the cross trainer, on the recumbent cycle, etc.
If I understand it correctly, in your initial research with men with bone metastasis, let's say if they had a metastatic disease to the pelvic area, you did not do exercises that stimulate that area a whole lot. But later on in your research, you said, what if we do stimulate these areas that have metastatic disease? And what you noticed was not only did it not get worse, but it can get better and perhaps some regression of the tumor by exercising the areas where the tumors are at specifically.
Yeah, Gio, it hasn't been well established in humans. It's been established in animals quite well. There was a very strong study done in rabbits and they found really good suppression. It hasn't been done in humans just because of the difficulty of actually tracking bone metastases in humans. It requires some advanced MRI techniques. We do have data around that, but I can't talk to it as yet. Probably the key is that we're exercising these patients and we were providing very controlled loading under highly supervised conditions. And we saw no fractures and no exacerbation of bone pain.
All right. So let's get down to some details, because as you mentioned, an exercise is medicine. With every medicine, there's a certain prescription, which requires intensity and all sorts of things that I go over with patients all the time. Let's start with the type of exercise. So in those studies that you've published, what are the type of weight-resistant exercise that are mostly utilized in those studies?
Certainly. In our studies, we predominantly implement machine-based exercise. So your pin-loaded machines. We do extensively now use sorry to use a brand name, but we use the Technogym BioStrength system, which is a robotic system which allows us to implement a very wide range of resistance training modes. We can implement an accentuated eccentric mode. And we believe that's very important, particularly for men with prostate cancer, because they have such a catabolic environment and they don't have access in the main. Most patients will be on testosterone suppression. And so they don't have access to that testosterone anabolic pathway. And so what we do is we have accentuated eccentric training where, for example, if you're looking at a chest press, for example, they might lift 60 kilos, but then they have to lower 80 kilos as an example. And so it's accentuated on the eccentric. We
So
find it's well
who's adding the
tolerated, but
weight?
it
Who's
also,
adding the weight? So they lift 60 and then somebody else would add, like, how does the weight adds on once they already lifted 60 kilos as a
sure, there's a number of ways to implement it. In research, in our clinical work, we use and I'm sorry to use brand names again, but we use the
that's okay.
TechnoGym
Yeah.
BioStrength system
Yeah.
because you can just program that in. It's a robot. So you can program that
Oh,
in
I see.
and it will just increase the loading. Practically in the weight room or in the exercise clinic, the easiest way to do it is load the bar up with 80 kilos. You help the patient lift it and then they lower it themselves. Then you help them lift it. So you're again providing accentuated eccentric. The other way to
So-
do it, of course, is you put 60 kilos on the bar, they lift it, and when they start to lower it, you just press down with it. The other way to accentuate the eccentric is to slow that phase down. So time under tension for the eccentric phase is longer. So that's really easy to implement. You can do that by yourself with no assistance. So if you're looking at squats, for example, you lower yourself down into the squats to a count of 4, and then you extend squat back up to say a 1 or a 2
one
count.
or as fast as you can do it.
Yeah. 4
So
down, 1 up.
So the main benefit is in the eccentric movement of most of these type of exercises.
Yes, particularly in men on testosterone suppression because they don't have access to the normal testosterone anabolic pathway. The eccentric loading activates a different pathway which is not reliant on testosterone. And so that's why we use it a lot with those patients.
Great.
Yeah. But also in general, eccentric exercise is quite a strong stimulus to muscle growth. It has to be implemented slowly. In the initial phases, if it's not done carefully, it can produce a lot of muscle soreness, which is not damaging, it's just uncomfortable. But yeah, we definitely use eccentric. The other thing is that we use heavier weights in general. So we use a weight that the patient can only lift perhaps 6 to 15 times. We don't have them doing 30 repetitions. It takes too much time for a start. It probably has the same anabolic effect, but it just takes longer and it's a bit unpleasant. And so we have them lift relatively to their own strength level, relatively heavy weights. We do large muscle groups. The key is we need to build a bigger drugstore. Okay? Our skeletal muscle system is our drugstore. It's pouring out anti-cancer drugs, medicines. We've got to make it as big as we can. Okay? Now it's nice to work on the bicep, okay? But it's a relatively small muscle. We do that. We try and maximize the size of all muscles, but we really focus on the large muscles. So the leg extensors, the gluteals, the large muscles of the back and chest.
So we're talking chest, glute muscles or butt muscles,
thighs,
back muscles, and thighs. Yeah.
Hams, quadriceps. Yeah, exactly. They've got the greatest potential for growth. We're trying to grow this drugstore as large as we possibly can. Because what then happens is every time you do exercise, even if you just go out for a jog or if you go for a walk, whatever, you're activating a greater muscle mass. So it's producing more of these myokines, which is causing greater cancer suppression and is also stimulating the immune system more effectively. And a whole bunch of other mechanisms I mentioned. There's probably 8 to 10 others. That's why, and that's coming back, recircling around again as to why we're seeing that people with cancer who have low muscle mass have much, much poorer outcomes. They're much less likely to survive. Another key factor in that, which we see very strongly, if the patient has to go into chemotherapy because the ADT drugs are no longer working, for example, and now we're seeing, as you would observe, many more patients are going on a doublet or triplet therapy now, where they're receiving the androgen suppression, the androgen blockers, but then they're receiving chemotherapy. Large amount of evidence across a wide range of cancers show that in patients with low muscle mass, the chemotherapy side effects, toxicities are much, much worse, and the dose reduction is much larger. In other words, because the patient becomes so unwell, the oncologist has to back off on the chemotherapy. They don't get as much into them because they're low muscle mass, they don't tolerate it. That probably contributes substantially to the fact that patients with low muscle mass have much poorer cancer-specific survival.
What are the other type of exercise? So we're talking, so number one is the type of exercise you do, anything like chest presses, lat pull downs. There's a lot of, for the listener, if you don't know what these look like, just YouTube videos they have plenty of these examples. Unless you have other resources and sources, Rob, where they can go to as well.
Sure.
Leg extensions.
Yeah, leg press, leg extension, squat, deadlift. All of these exercises are fantastic for that. I
So
think a key point is that
go ahead.
in
I'm sorry.
2019, we published the Australian guidelines for exercise medicine in cancer management. And it was a considerable diversion away from current international guidelines because we went to a more tailored precision exercise medicine model. What we're now proposing and what we're now actually implementing is that it's highly important to assess the patient extensively, their health and their fitness, determine those characteristics which are placing the patient at most risk of mortality or morbidity, and then designing an exercise prescription highly tailored to target those most problematic or highest priority issues. I give the example of low muscle mass or sarcopenia, for example. Major problem, about a third of cancer patients will suffer from this. And it compromises their ability to survive the disease. It increases their risk of other diseases like metabolic syndrome and cardiovascular disease accelerating. So for these patients with low muscle mass, the focus of the exercise prescription must be on building muscle hypertrophy. It has to be on stimulating as much muscle drive as possible. So it's resistance training, high volumes of resistance training. And in fact, it should minimize cardiorespiratory or aerobic training. In some cases, particularly in patients which are highly sarcopenic or even have cachexia, which is an uncontrolled loss of body weight, for those patients, aerobic exercise is contraindicated. They need to avoid it because it's only going to accelerate the decline. On the flip side, if the patient has very high cardiovascular risk, okay, their cholesterol's through the roof, blood pressure, etc., they're overweight, whole 9 yards, the emphasis has to be improving the efficiency and effectiveness of their pulmonary system and their cardiorespiratory system. And so that's where the focus is. So we're recommending a highly structured approach to this where you assess the health and fitness of the patient, body composition included, strength, cardiorespiratory capacity, pulmonary function, and then design a tailored prescription which focuses laser-like on those issues which are most likely to cause morbidity or mortality.
Love it. All right. So types of exercise we covered. So here's what I do with patients. It's because you have to meet them where they're at, right? And what they're capable of doing, and if they're going to fitness centers, et cetera. I'm a huge fan. Not that you need to follow me on Instagram, but every now and then I post my workouts, and I'm a deadlift fanatic. If you're going to get
exercise,
the most bang for your buck, where almost every muscle is stimulated from your neck to your toes, is deadlift.
Yep.
Functional. Very difficult. People talk about on the internet and on social media of injuries. Yeah, you could get injured from walking down the street, but very difficult to get injured from a deadlift done difficult. So you just drop the weight if it's too much. Unlike a back squat, which I also am a big fan, but I can see a back squat, the technique is a little bit funky. I'm always improving on my techniques. I've been doing it for years. So I understand back squats, but deadlifts, particularly if you use what's called a hexagon bar, right?
Yes.
Where you're in the middle and you lift, just by having that, your body in the center of the weight, is almost impossible to get the technique wrong. So I'm a fan. All my patients like deadlifts. Now, it depends what they have at home, right? Okay, kettlebell deadlifts, if that's what you can get. And you get to kettlebell, it's this little weight, and you just put it in a corner, and it doesn't take a lot of space, and you could get a lot of bang for your buck on utilizing a kettlebell. But so that's one of the, I don't want to get too down into the weeds with that, but that's one of the approaches that we utilize in our clinic. How do you measure when you say intensity? So this is what I tell my patients, and you could tell me, please feel free to tell me if I'm getting it all wrong. Number one is learn the technique of any exercise really well. Number two, if you could do 30 reps, I think like you mentioned, like that weight is too light. You want to hang around, I tell them between 6 to 12 reps is what I tell them. And that last rep, if you plan to do 6 repetitions, you may have 2 more in you, but you stop at 6. Or if you do 10, you may have 2 more in you, you stop at 10. How do you communicate intensity as it relates to weight resistance exercise to patients? Is that more or less in the ballpark?
Well, it certainly is, Gio. It's called reps in reserve, and we suggest that they have 1 to 2 reps in reserve. So we recommend that the patient select a weight and do the number of repetitions where they have 2 reps in reserve. So as you did, exactly how you explained, that they could do another 2 in the set before total failure. With athletes, we push them over that limit all the time, but for a patient, there's no necessity to do that. They do have to live close to that because we have a range of motor units in all of our muscles, from very slow endurance motor units right through to our very fast motor units. And so again, to grow muscle and to improve function, we have to activate as much of the motor unit pool as we can. So if we only lift light weights and we stop 6 or 7 repetitions short of failure, we're never activating the very fast motor units. And so we're not utilizing that pool there. We have to activate the whole pool. And so that's why, again, we work around the 6 to 15 repetition range, but we always say, look, leave 2 repetitions in reserve. Exactly what you said.
Volume. Explain what this means to people and how. So to me, it means more reps and then more sets, the more certain amount of sets that you do. Let's make sure that the language is right, that I'm interpreting it correctly. And if so, what is the magic number in terms of how many sets or reps one should do? Or total amount of reps? We did say between 6 to 15 or so, but how many of these sets should we do or should they do?
It is very much where the patient's at. When our patients first come in, we only give them 1 set of each exercise. We don't want to make them sore. You won't see them again. And so they only do a single set and they don't go anywhere near failure. We might do that for a week or so to see how they tolerate. And then we start to add multiple sets to each exercise. We try to get to around 3 to 4 sets of each exercise. But again, it all depends on what the patient, what access they have, what level of supervision. One of the key drivers of adaptation is variation. And so what we try to do in our clinic is constantly be doing different exercises, different speeds. We slow the eccentric phase down. We speed the concentric phase up. We change the positioning of the hands, the positioning of the legs. So we don't come in, the patient does the back squat, the same foot position, hip width apart, the same position every single time. So we have them come in and we'll go wider, we'll go knees out, we'll go sumo position, etc., constantly changing, because such well-established research from 30 or 40 years ago shows that the adaptation stimulus to the neuromuscular system is much greater when there's high levels of variation. So we're constantly changing it. We use periodization. Now, periodization's been used with athletes for probably 2-3 millennia. In the ancient Greeks used to use it. It hasn't been used in the clinical setting, but over the last 10 years, we've been implementing it with patients. And that's part of our 2019 guidelines that we produce for exercise medicine.
Why don't you expand on that, what that means, periodization?
Periodization is the manipulation of the intensity and volume of the training across different cycles, short cycles of perhaps a week, a month, and then a 3-month period. And over the week, the patients, if they're doing 3 exercise sessions per week, then we'll start the week with perhaps a high intensity session, then they'll go to a low intensity, and they'll finish the week with a moderate intensity. And the same, we manipulate not just intensity, but also volume. We don't have them doing the same thing every single time they come in. We also then periodize it over a month so that we increase the volume and intensity up, and then we drop it back down at the end of the month, and we do that over 3-month cycles. We also periodize the exercise prescriptions around key events. Probably the classic is around chemotherapy infusion. So if we're leading the patient up to their next chemotherapy infusion, say over a 4-week period, is that we'll increase the intensity and volume leading up to that point, just as we were doing that with an athlete. An athlete preparing to compete in the Olympic Games or whatever.
Love it. I love it, Rob. That's all I have for you. Thank you so much for being on. I really appreciate you and your time and all the work you've done around exercise oncology. Thanks again for being on. Thank you, everyone, for watching this amazing episode. I'm so stoked from this. I want to exercise right now. And in my time, it's almost time to go to bed. I'm so excited about this conversation. And you've heard me turn blue in my face. Exercise, if I have to choose one, exercise by far is the best medicine. So hopefully you take action, and hopefully you're inspired by this, regardless of where you are at in your stage and grade of prostate cancer. If you have it, doesn't matter. Get moving. And if you want to do a little bit more, get a little weight resistance and you go a long way. Thanks again for joining us. This is Dr. Gio signing off. Much love. I'll talk to you next time.
We hope you enjoyed this episode. You will continue to receive powerful interviews and insights to support your prostate health journey. For those who want to dive deeper, our exclusive membership offers even more. The Dr. Gio Prostate Podcast is here to provide you with information and support on your prostate health journey. We are introducing our exclusive membership,
where you can get even more value from every episode. Every episode comes with detailed show notes, breaking down the key points so you don't have to take notes while listening. You'll also get curated transcripts so you can read and revisit everything you just heard. Perfect for learning at your own pace. And for every episode, you'll receive a handy list of resources. Products, links, studies, and tools mentioned in the show, all in one place. That's not all. Members also enjoy special discounts on hand-picked products to support their health and wellness goals. And there's more. Members get exclusive access to Dr. Gio's monthly Ask Me Anything, where he answers questions submitted directly by the community. All of this for just $19 a month, or save 20% when you pay annually at only $182 a year. Smarter listening, deeper learning, better health. Join the Dr. Gio exclusive membership today. Start getting more from every episode.
Thanks for tuning in to this week's episode of the Dr. Gio podcast. You can watch all episodes of this podcast and much more by subscribing to my YouTube channel. If you love what you heard today, you can help by leaving a 5-star review of the podcast on Apple and Spotify, as each review helps us reach more men who are serious about improving their urological health and how to function better with age. And for the latest research and actionable takeaways in the world of men's health and integrative urology, sign up for my newsletter at drgio.com. I'll see you next time.